Hello, everyone. I'm Shannon O'Brien, a Regional Medical Program Sales Director here at Kaplan. We want to thank you all for joining us today for our special webinar on enhancing clinical confidence and competence in virtual simulation. I'm joined by my esteemed colleagues, Dr. Christy Doherty, our Executive Director of Nursing and iHuman Patients, Dr. Maria Ojeda, our Director of Nursing Research, and Andrew Smith, our Regional Nursing Program Sales Director. Drs. Doherty and Ojeda will present key findings on how virtual simulations enhance clinical confidence and competence in nursing students and how integrating tools like iHuman Patients can directly improve student outcomes and prepare them for real-world clinical settings. After that presentation, Andrew Smith will run through a brief demonstration of a case and reporting available on our iHuman Patients simulation platform. I'll now hand over to Dr. Doherty.
Christy, you're on
Thank you,
mute.
Shannon. As nurse educators, we share a common purpose: to prepare students, whether nurses or nurse practitioners, to provide safe, competent, and patient-centered care. The goal is to ensure that every graduate leaves our programs confident in their knowledge and competent in their clinical decision-making, because we know that those qualities are essential to achieving patient safety and optimal outcomes. How do we accomplish this goal, though, varies. Some of us teach in the simulation lab or the classroom, others at the bedside, some through policy work, curriculum development, or administration. But no matter where we teach or what our job title is, all nurses are educators. Every interaction with a student, a peer, or a patient is an opportunity to teach, to lead, and to model clinical reasoning in action. That's why we work so hard to develop and implement strategies that are not only evidence-based, but also active, engaging, and experiential. We know that passive learning does not build skill or confidence. Students need opportunities to practice, reflect, and apply their knowledge in meaningful ways. Simulation is one of the most powerful tools we have to do this. It comes in many forms: low-fidelity models, high-fidelity mannequins, standardized patients, virtual reality, screen-based cases, and more. But as educators, we know that not all forms of simulation are easily accessible or easily integrated into our programs. Clinical space is tight, time is limited, and resources are not always equitable. And for online or hybrid learners, options like mannequins or standardized patients may not even be feasible. So we ask ourselves, how can we provide consistent, scalable, and meaningful clinical learning experiences? How can we ensure students are not just checking boxes, but actually building confidence and clinical competence? And that's what led us to the research. What do we want to know? And we wanted to know whether the remote access, screen-based virtual simulation, especially iHuman's case-based simulations, could effectively support the development of clinical confidence and competence among learners. Here are the definitions of a few core variables that shape the study. Clinical confidence is the student's internal sense of trust in their own clinical judgment and nursing knowledge. It's that voice that says, I know what to do next. Clinical competence is the observable ability to integrate and apply that knowledge to real patient care. Confidence fuels action, competence proves it. Virtual simulation refers to immersive, computer-based environments that mimic clinical scenarios. They allow learners to interact with virtual patients, make decisions, see outcomes, and reflect, all without risk to real people. Student engagement is the energy and the effort students invest in learning. Highly engaged students are more likely to be present, reflective, and retain what they learn. Student engagement is not directly measured in our research, but correlates to case-based simulation scenarios. These four variables form the framework for understanding how virtual simulation might impact nursing education. This isn't really a new area of interest. Research over the past decade has demonstrated strong relationships between simulation-based learning and improved educational outcomes in undergraduate nursing programs. What's changing is the technology and our ability to personalize it. What we want to know now is whether these same benefits extend into graduate level education, where learners are a bit more autonomous and expectations are high. And so we looked into the evidence and drew on multiple threads in the literature. Let's look at a few key articles we found. Gu and Sock in 2021 examined a flipped simulation model and found that confidence, or self-efficacy, was the most powerful predictor of academic achievement in nursing students. When students believed in their capabilities, they performed better. Brackney et al. In 2017 drew a more direct line to licensure outcomes. Students who were perceived as confident and competent during high-fidelity simulations had higher NCLEX pass rates. Confidence is not just a soft skill, it predicts behavior, it shapes outcomes, and it can be nurtured. Competence, meanwhile, is the execution, what students do with their confidence in the clinical setting, and that's why we felt that they should be studied together. Now, what about virtual simulations specifically? Guerrero et al. In 2022 studied practicing nurses and found virtual simulations significantly boosted their knowledge scores post-simulation. When compared to high-fidelity simulation, virtual participants scored higher in knowledge, while mannequin simulation scored better in skill performance. Medell et al. In 2024 found improvements in both knowledge and satisfaction among undergrads after a virtual case on respiratory conditions. Students appreciated the usability, realism, and clinical applicability. Eggleslotier et al. In 2023 showed that e-learning, including virtual simulations, resulted in measurable improvements in confidence and competence. But here's the critical gap. Almost all of this data is from undergraduate students. What about advanced practice learners? A lot of the studies focused on graduate students are either qualitative, descriptive, or inconclusive, which limits generalization, and that's where part of this research steps in. Why does engagement matter? Because even the best designed simulation is ineffective if learners aren't invested. Engagement has been directly linked to outcomes. Sarimbas and Riccio in 2019 found that younger students and those with high engagement in online courses had better grades. But Hensley et al. In 2021 documented low engagement levels in BSN and DNP students. Online learning without interactive features can lead to passivity. Virtual simulation addresses that by being immersive and decision-based. It makes learners active participants, not passive viewers. Now I want to discuss our graduate student data. The research we conducted was a quantitative descriptive study. Participants included graduate nurses, physician associates, and medical students who used the specified iHuman simulation cases. We analyzed the respective data that was collected from January 1st, 2023 to December 31st, 2024. The instrument, or rather the survey questions, were collaboratively developed by teams in nursing, learning science, and research. It was validated for face and content validity. Students rated their agreement with 2 statements on a forced choice Likert scale from 1 to 4, with 1 being strongly disagree and 4 being strongly agree. The 2 statements were, I feel confident that this simulation contributed to my clinical knowledge base, and after completing the simulated experience, I have the knowledge to competently choose the next best step in this patient's encounter. Let's take a closer look at how the iHuman virtual simulation cases used in this study were structured. Each case was designed to walk the student through a realistic step-by-step clinical encounter, mirroring what they would experience in practice, but within a safe and interactive digital environment. Each case begins with a set of instructions. These serve as a similar purpose to a pre-brief, orienting the student to the platform, expectations, and scoring format. Importantly, the instructions don't reveal the clinical scenario or the diagnosis, allowing students to engage with the case authentically and begin building trust in the learning experience. Students start by gathering information through 2 key components: a virtual electronic health record and an interactive patient interview. This combination encourages integration of both documentation and subjective data, just like in real practice. Since we know that up to 80% of diagnoses come from the history alone, this part of the simulation is intentionally detailed. Students also have the opportunity to practice documentation through note writing, building both confidence and competence in clinical communication. Next, students perform a virtual physical exam, selecting relevant components based on their clinical reasoning. This step reinforces safe decision-making, encouraging the learners to think critically about which findings are most useful. Assessment. Here's where the clinical reasoning takes center stage. Students identify key findings, interpret pertinent positive and negative, and begin forming a differential diagnosis. They then synthesize that information into a structured problem statement, which can double as a practice handoff or a preceptor presentation, supporting both clinical clarity and professional readiness. Once the differential is established, students order diagnostic tests to confirm or rule out conditions. This step encourages evidence-based thinking, emphasizing test selection based on utility, cost, and invasiveness, not habit or guesswork. Using their assessment and test data, students select a final diagnosis and construct a care plan. The plan includes writing orders and selecting appropriate interventions aligned with current guidelines. Each case ends with an automated interactive debrief. Students receive feedback on the actual diagnosis, along with reminders that highlight key decision points, missed opportunities, and what made the case unique, allowing them to reflect and refine their clinical judgment. Now I'm going to hand it over to Dr. Ojeda to discuss the results.
Okay, thank you, Dr. Doherty. So as you can see, this slide depicts the results for the graduate student data set. But before I go through the results, I wish to note that prior to the analysis, we excluded the cases with less than 100 responses. That's in order to mitigate the potential to introduce non-response bias into the data set. Then we analyzed the data using straightforward descriptive statistics, including a count of the number of responses to each question, the average number of responses to each question, the number of unique cases accessed by respondents, and the proportion of favorable responses to each question. A favorable response was defined as the sum of the proportion of agree and strongly agree responses to each question. So we collected a total of 109,857 responses to our question about clinical confidence. The average number of responses to each case was 499, and the number of unique cases represented in the data set was 220. To our question about clinical competence, we received a total of 115,296 responses. The average number of responses to each case was 515, and the number of unique cases represented was 224. If you look at the pie chart, it depicts the proportion of favorable responses, which was high for both questions at 83.8% of respondents. So the results for the analysis were very positive. And so I'll hand it back to Dr. Doherty.
Thanks, Maria. Now, before I jump into a discussion about our conclusions of the graduate nurse study, I also wanted to share some undergraduate research we were doing on the same topic. We did this research so we could examine consistency across educational levels and detect any trends or differences in how simulation is experienced and perceived. In this study, the undergraduate students participated between November 2024 and March 2025. They used the same case-based virtual simulation format and responded to the same survey questions on confidence and competence. The structure of the undergraduate simulation experience is very similar to the graduate version, but with some purposeful adjustments to support learners who are still building foundational clinical judgment. These cases also align closely with the NCSBN clinical judgment measurement model, helping students develop the habits of thinking they'll need for both clinical practice and licensure. So let's walk through the case flow. Undergraduate simulations begin with a pre-brief style set of instructions, but unlike the graduate version, these include reflective questions. Students are prompted to consider what they already know about the presenting condition and what information they might still need, and how they might approach treatment. This additional support is designed to help students who may be less familiar with clinical reasoning start to activate prior knowledge and prepare to think critically. As with the graduate simulation, students review an electronic health record and conduct a virtual patient interview. These steps help them practice integrating documented history and subjective patient responses, building the foundation for identifying key problems. Documentation is also built in here with the opportunity to begin composing their nursing notes. Students select components of a focused physical exam, practicing how to tailor assessment based on clinical cues. This reinforces the connection between what they find and how they will interpret the data later. Analyze. This stage functions similarly to the clinical reasoning portion in the graduate simulation. Students identify key findings, determine what those findings mean, and begin formulating nursing diagnoses or clinical problems. Then they rank those problems in terms of urgency, labeling them as stat, urgent, or routine, which guides their planning process. Based on their prioritized problems, students select appropriate nursing actions. These might include clinical interventions, communication with the care team, or support measures tailored to the patient scenario. It requires learners to connect clinical findings to real decision-making. Students document their thinking and care decisions in a structured nursing note, reinforcing clinical communication and professional writing skills. This step not only builds competence, but also confidence in articulating their rationales. Finally, each case concludes with a guided summary and debrief. Students receive feedback on the scenario and are prompted to reflect. What went well? What would they do differently? And this encourages metacognition and helps them carry their learning forward into future cases and clinical experiences. Now, Dr. Ojeda will share the undergraduate results.
Okay, so as you can see, these are the results for our undergraduate data set. The analysis that was performed on the data was identical to the one for the graduate data set. And we received a total of 23,962 responses to our question about clinical confidence, and just one fewer to our question about clinical competence, so 23,961 for that one. The average number of responses to each case was 631, and the number of unique cases represented in this data set was 38 for both questions. As you can see on the pie chart, the proportion of favorable responses was high for both questions again at 82.2%. Really quite positive, just like the graduate results. Back to you, Dr. Doherty.
Thank you. So what did this research reveal? Our findings mirror and extend earlier work in undergraduate simulation research. This study contributes to the growing body of evidence supporting the value of simulation in advanced practice education. The patterns we observed, strong self-reported gains in confidence and competence, are consistent with outcomes seen in undergraduate populations, confirming that simulation benefits learners across educational levels. Across thousands of responses, the data shows a clear trend. Students perceive virtual simulation as a meaningful tool that helps them feel more clinically prepared. These simulations allowed learners to apply knowledge, make decisions, and reflect in a safe, structured environment. And that repeated exposure appears to directly influence how confident and capable students feel in their clinical reasoning skills. And aligning these outcomes may ultimately support better student performance in clinical rotations and contribute to higher success rates on certification and licensure exams. While this study did not measure long-term academic or practice outcomes, the link between confidence, competence, and clinical performance is well documented. If students feel more prepared and are more prepared through simulation-based learning, they may perform more effectively in clinical settings, communicate more clearly with patients and preceptors, and approach certification and then licensure exams with greater assurance and clinical insights. Virtual simulation is not a complete replacement for clinical hours, but it is a powerful supplement. It offers safe, repeatable, and scalable practice. It builds confidence, reinforces competence, and provides realistic clinical decision-making opportunities for students at every level. All the evidence cited today is listed here, including both foundational studies and emerging research in simulation and nursing education. Now I'll turn it back to Shannon.
Thank you, Drs. Doherty and Ojeda. We will now have Andrew Smith proceed with the iHuman Patients demonstration. Andrew?
Thank you all, Dr. Doherty, Dr. Ojeda. It is fantastic hearing a lot of the research that's behind it. But what we also wanted to take some time and do is actually showcase what that actually feels like playing through a case. So what you've got in front of you now is going to be the screen for the iHuman Patients platform. As we get to the landing page, you will see that we have this nice little friend here that's going to give you some guidance as far as a virtual walkthrough, some orientation videos. Again, any type of help videos here. These get a little bit more detailed depending on if we're talking about graduate or undergraduate. So we do have a nice walkthrough there. But what we want to do is actually introduce you to a case. So I'm going to go ahead and start that now. We are going to walk through Lawrence Lee together. But before we get started, I want to understand what we're going to be looking at. So this is a faculty giving the student to a case. What you have the ability to do before you even get into one of these cases is actually see kind of the Cliff Notes version of what you can expect your students to see. So whether you're using iHuman as a pre-brief for clinical, a debrief for clinical, whether this is a homework assignment or you're going to be using this in a flipped classroom, you're going to understand what the students are going to be seeing going into. So we're going to show the learning objectives here, the clinical preparation, what diagnostic testing they can be expected to find, the key findings we're going to be looking for, anything specifically to the differentials, as well as treatments, as well as those references. So you do not necessarily have to play through every one of these cases yourself. You're certainly welcome to. We want to make sure you have the information needed to make sure that those students are going to have a great experience. So let's get started. Let's go ahead and see if we can get started with Lawrence Lee here. As we get presented with the patient here, I'm going to go ahead and mute him. We're presented what Dr. Doherty explained at the beginning. This is our interview section. So we have the ability to now ask Lawrence Lee a number of questions. And this is already really where we start to unpack where your students are going to go through their learning journey. So we've got a gentleman that's got COPD, long-term smoker here. So you see here for an acute exacerbation. So what do we want to start? What questions should your students start? Do we want to start asking about how long it's happened? How long has this cough been happening? Or do we want to take time to acclimate the patient? How can I help you today? Difficulty breathing here. Do you have any other symptoms we want to? He's coughing up some fluids now. What's most distressing? What is your name? How would you like to be addressed? Where are you? These are vital questions to make sure that the patient is experiencing a normal patient encounter. We certainly wouldn't expect your students to walk into a patient and just start shooting questions right from the hip, right? So we want to make sure we're documenting everything like that. We can certainly search through questions. So again, if I wanted to, for example, let's look for a cough. We see anything that's going to have cough in it. But there's another way we could go about this too. Again, he said he is having a wheeze. As I type in the word wheeze, I do get, do you wheeze, right? So that's a great question maybe to ask. But I also get, are you short of breath? So this has now got a lot of smart search features that are built into it now. So where not only do you have to type the question exactly right, anything that's parallel to that question you're asking is going to pull up. So for example, when did is going to pull up a lot of things. So when did your rash start? How old are you, right? So that's when did your birth, like there's a lot of things that are parallel. So we're trying to make the student experience really, really easy and easy to navigate. But we do want to make sure that we're documenting our findings as we proceed through this case. So as we go through these patient encounters, we want to make sure we're asking pertinent questions, but not extraneous questions. Fairly straightforward here. I'm going to proceed through the next part of our test, which is going to be the physical assessment side. But before I get there, it is going to ask me to do a couple of things. If you'll notice in the top right, I'm in a learning mode case. iHuman cases come in two separate case styles, learning mode and testing mode. And as you probably understand, learning mode is driven to be newer students, content more driven. Testing mode certainly has the ability to kind of like do some higher level testing. But in learning mode, every section that a student passes through, there's a preceptor that's going to guide them through that learning journey. So for the history section here, we're going to just kind of inform the students what we're looking for. We want to list the full list of concerns, characterize these symptoms, and it's going to showcase what I'm going to be looking for. So these are the questions I asked that were appropriate. How can I help you today? What other symptoms do we need to discuss? Something I did not ask that the case author absolutely says must be asked is, do you have any allergies? Right? Super important as we go through and start to make some of these differential diagnoses, making sure we've identified any types of allergies here. I could certainly go back to the patient now and I could go through and ask that allergy question just like I was supposed to. Do you have a rash? Do you have any allergies? Perfect. So now that we've accomplished everything we needed to on the piece there, we're allowed to go ahead and move through the next section. And this is really where iHuman opens up and blossoms even further. So now we're going to be asked to perform a physical assessment to help guide our diagnostic process. So again, we operate these a couple of different ways. Some of these we're just going to give the students, right? Height. They don't have to get out a tape measure and measure them. They're going to get given 5'11". Weight, right? You don't have to move the little slidey scale on that, right? Those are just going to be given. But that said, there are times where we are going to be asking the patients, the students to actually perform an exam. So again, we're going to do the blood pressure, for example. So is the patient lying or standing? We can see that pretty easily here. Location for the cuff. Does he have an IV in the right arm or the left arm where we may need to move the cuff to the other side, right? That's something we want to make sure we're doing here. We're actually able to perform the blood pressure exam. And I am going to do this incorrectly, so the academics among you, I apologize. It's just for show here. And we'll pop it off a little bit early here. I'm going to be asked to perform the interpretation now. Now, the other really important part of iHuman to understand is this is kind of what this heartbeat would sound like. This is a medically recorded actual heart sounds. Again, we're asking your students to make differential diagnoses based off of the auditory cues that they're going to hear, whether that's an auscultation, whether that's where we're listening to heart noises, whether we're doing blood pressure, right? They're going to be asked to perform those exams and they're going to have to recognize those auditory cues. For that reason, again, the audio as it comes through the speakers may be a bit staticky, or I've heard before. We always encourage to use the headphones because they want to make sure they get that high fidelity piece in there. And that's the other part of this. Everything that's going to be documented in iHuman is an actual mechanical recorded noise or picture, as will later unfold. So let's go through a couple of other assessments here. 87% O2 levels. Let's definitely make sure we're documenting these findings on the right-hand side here. Those are my notes. I'm going to be asked to kind of organize my thoughts in a bit, but I do want to make sure I've got a running tally of the things that we've uncovered with our patient here. And you can see here, this is going to have a very far wide range of assessments we can perform. Gait, mental status, skin, inspecting nails here. But again, just because we can perform the test doesn't necessarily mean we should. So for example, I can click inspect the eyes, and it's just going to tell me what we're supposed to be seeing. Then I can go in and actually examine the pupils, right? And I'm going to be asked to make an interpretation based off of what I've seen there, right? How are they reacting? Seems pretty straightforward to me. Let's do an ocular motor test, H test, right? Like we can certainly perform that test there. And again, we can even go as far as doing the optometroscope. And again, this is an actual medical image here. I can scroll in, out, flip it around, do all kinds of fun stuff there. But it begs the question, is this pertinent? I've got a patient here that's 70, COPD, having a hard time breathing. Do I need to be giving him a full eye exam workup? Maybe, maybe not. But I do want to just call that out is they can do any type of assessment they needed to, whether that's going to be an auscultate the heart, and you'll see here that is going to be guided here. They're going to get a little bit of this, like which order to follow these through. But keep in mind, we're in a learning mode case. As these students get presented testing mode cases, they may just show it this. And being able to make sure that they follow the correct pathway through these auscultations for the lung and heart is something that they will absolutely be graded on. Last thing I want to point out is there is a full range of workups that we can do for these patients, including exams that are not gender appropriate. For example, assessing the fetal heartbeat sound on a male patient probably doesn't make any sense, as well as examinations that may be uncomfortable and inappropriate to perform for the patient. They are allowed, your students have full range. This is a full sandbox simulation. They are allowed to go wherever their heart's desires, but making sure that they're able to accurately and ethically pick the correct responses and exams to perform for the patient is absolutely paramount for them to be able to be effective in their studies. For the time being, I do want to pull up one other one, and I just happen to know this one because I have played with Lawrence Lee before as well. Just because it shows up doesn't necessarily mean it's pertinent for the case. For example, Lawrence Lee actually has some clubbing of his nails. As your students uncover that, whether they recognize that as being an auxiliary separate concern or related to the case, it'll be up to the students to decide. For the time being, I am going to go ahead and proceed to the next section here. And like we had mentioned before, in a learning mode case, at the end of every single section, we now have that preceptor that's going to guide us through this. And as they get further and further through these cases, that preceptor gets more and more involved and driven in by the content here. So again, we are going to go ahead and give them some high level what we're looking for on the physical exam guides. And you're going to see I've done some things here correctly, some things incorrectly, and there will be some things that are inappropriate. So cognitive status, I didn't do that, right? Just completely missed it. Height, not required, not wrong, got there. Blood pressure, let's see what it did to here. I performed it, but I interpreted it as narrow and it should have been normal. I put in 120 over 90, should have been 154 over 92. You do get a little bit of a wiggle room there, but I'm certainly well outside of that there. The assessment was incorrect, and I also didn't listen to both sides there. Pulse, didn't do that one at all, right? SpO2, that was correct. Inspect the nails, perform that one correctly. All great. Assess fetal heartbeat sounds, completely inappropriate, right? As it goes without saying. These are additional exams that I had performed that were not required for by the author, not necessarily inappropriate, just not pertinent to the case. I, again, like always, can go back to the patient and perform any other exams. That smart search feature works here the same way it works anywhere else. If I needed to do, I can type in leg and get lower extremity. And the other thing I can do here is document all of my findings in the electronic healthcare record. So at this point in time, I would take the time to document our O2 levels here and things of that nature. So I'm going to proceed for the time being. I am going to go ahead and skip through this multiple choice for our time's sake here. And this is where I'm going to kind of pause on the case playthrough. This obviously unfolds into a very, very in-depth, detailed case overview. I'm going to be asked to organize my findings, write out a full problem statement, and we're actually going to start getting into the differentials, right? We're going to start identifying the disease states that are pertinent, ranking those differentials and ordering tests, as you can see through the top here. For the sake of time, rather, we're going to go ahead and pause on that. But I would strongly encourage you, if this is something you would like to see some more of, we would love to take the time, one-on-one, spend an hour together, and really go through a full case through together, ask questions, be involved. So again, if that's ever something you want to do, Shannon's definitely going to leave a link later down in the line for a survey. But again, if this is something you want to see, we'd love to spend some additional time together. The last thing I want to take some time and do is actually review the reporting suite. So Dr. Doherty has really explained the high level of how this whole process works. We've kind of glimpsed a little bit here at the 30,000 foot view of what that looks like for your students. But what I want to do now is unpack this in a real classroom setting so you can understand how you could leverage iHuman. So let's go on a little make-believe journey together. Let's say we gave Ben Bundy out for your cohort. It looks like you've got 197 students, and you want to give this as a homework assignment. Again, this can be used as a pre-brief for clinical debrief. You can play these in the classroom. There's a lot of ways to do this, but let's use the example of homework assignment. You gave it to them on Friday. Hey guys, over the weekend, let's go ahead and play through this case together, and we're going to unpack it on Monday. So you come into your office Monday morning, bright and early, and you walk in and you already see that only 52% of your class even did the case at all. And that's the reality of sometimes what you guys have to do as faculty. But we do have 104 students that played through the case. So let's see how they had gotten on. We get a scatter graph here of the score. So we're going to rank them on the electronic health record, the history, physical assessment, the overall score. It looks like your students were between the 50 and 80% range. Not too bad, kind of hanging there in that median range. A question we always get, how long should an iHuman case take? Good question. I think this is a really good reflection of that. On the low side, 30 to 45 minutes, as the students get more comfortable with the platform or it's a more streamlined case, maybe on that lower side. These more involved, difficult cases, probably on the hour and a half side. Let's think about it in a round setting. How long do you think that should take for a patient encounter to happen on a 12-hour shift? It should certainly not be almost 4 hours, right? So that's something that's going to jump off the page for you right away. And in that next section, where did we spend that time? You can see it right away. I had a student that spent 2 hours on the history section. Let's put our place back on that patient bedside encounter. COPD, 87% oxygen levels, wheezing, tripod. We found out later, I'll spoil it for you. He's barrel chested. The man's having a hard time. Maybe taking 2 hours to ask him questions isn't the best thing for our patients to be doing, or our faculty to be doing with that. And again, it took somebody almost an hour and 45 minutes to write their nursing notes. Again, this is a piece where you can pause it and come back to it. So again, did we go grab dinner or a nap? What was the reasoning there? You can certainly unpack that with the individual students. And then we are going to share the bar graph. Just again, another way to data visualize on our reporting suite. So how did we score on the electronic health record, the history, the physical assessment. Pretty straightforward on that side. What is the most unique and intriguing about iHuman that you cannot get in a clinical setting or a virtual simulation setting, rather? Frequently missed tasks across categories. Where did your group of students fall down as a group? So again, keep in mind, 104 is our end count. Out of 104, 103 of those students did not ask, are you experiencing any violence, abuse, trauma, or bullying? If so, by whom? How easy is it now for you on Monday morning to present to the class? Gang, I know we just played through this case. I want to bring something up though. 99% of you overlooked asking this particular patient, are you experiencing any violence? This is super important in this situation because, right? And it's just that easy to fill in that knowledge gap or that content gap. Same thing, 98%. When was your last bowel movement? Do you wear dentures? Any valuables? When you're talking about 9 out of 10 students missing something on a task, that's a content gap, right? That's your best students, that's your underperformers, that's everybody. So really, really easy and straightforward for you now to identify that and then fill that gap in for them for next time. We do have that on the other side as well, extraneous tasks. So again, 104, it looks like 98 of that 104. Why did you all feel the need to palpitate and percuss the anterior and posterior chest? That's not pertinent for this particular case because same thing, palpitate the extremities. We drop into the 70s and 80s. But again, when we've got 80% of the student population trying to palpitate the extremities and it's extraneous, we want them to not do that, right? We want to drive that efficacy rating up. And the final way we help you to report and monitor that is what we call visual performance across categories. Now, we've got a lot of folks here with us. I'm sure some will be sports fans, maybe not. When I look at this type of graph, that's kind of where my head goes. This kind of looks like a sports graph. When we go through this here, it looks like we had required history questions in 39. So it doesn't look like anybody got all 39 questions correct, but we got 28 correct, 58 extraneous. So that's a pretty high count. But as we get over here and we see 19 correct questions out of almost 40, right? We're going to call that 50% work. 102 extraneous tasks, extraneous questions. So again, let's go back to the bedside. Guy can hardly breathe, and we ask him 100 questions, literally 100 questions. Now let's go ahead and ask that student, why did you feel the need? What is it that you were searching for? Did you not feel comfortable, right? Did you not have that confidence built up? Why is it that we felt the need to go down this rabbit hole? And we still didn't actually get to where we needed to. We still missed over half the questions we needed to ask. The same thing happens on the physical assessment, right? So we had 27 required by the case author, recommended by the case author exams we wanted to perform. So again, down here in the greens where we want to be, 25 physical assessments performed that were accurate, 17 that were extra. That's not too bad here. As we get to the top though, 25 physical assessments performed out of the 27, 67 additional extraneous exams. That is a tremendous amount of additional work to put that patient through, right? Why do we go down so many different tests? This isn't a sitcom on TV. We cannot just order every test that we can think of. Why did you feel the need to go through so many tests? And not only do we give you the ability to see that at the high level, you can actually sort by it. Now, I do want to keep in mind, these are not real students, right? This is a demo account. These are not real folks. So I'm going to pick on Annabelle right now, but I just want to make sure you know Annabelle's not real. So she's okay. We're going to go ahead and explore this together. So I went in as a reporting suite, and now Annabelle's in my office because I pulled her to the side. I was like, we want to maybe review some of these case findings on this particular case. So the median of the group was here at 65%. We scored a little bit lower than that here. We can kind of see how they rank on that bar graph. But let's see what individual responses the student elicited here. So 15 minutes in the electronic health record. We got a few of them right. Missed a couple of these here, but again, not too bad here. As we get into the history section is really where this starts to unravel a little bit. 51 minutes. I've said it a few times. Guy's not doing super great, trouble breathing. We spent 51 minutes rather asking him questions here. So what is it that we were asking? Some of these are correct. Do you wear dentures here? What is your name? These are ones that may not be appropriate here. And you can kind of unpack, why did you feel the need to ask this particular question? Are you able to drive? Why did you feel the need to ask that? Have that student have that discussion with you. As we move forward into the physical exam, 16 minutes. Let's see what they had unpacked here. So a lot of these were right. Inspect here. These are fine. Missed the blood pressure. Auscultate fetal heartbeat. Someone else is asking about the baby heartbeat. Is this a misclick at this point? Why are we clicking on these types of things? Performing a female exam, male patient. whoa, right? Like major red flags. This patient was this student either went through this case too quickly or was just clicking around, but we didn't give ourselves the best performance here. But I just want to call out the ability at an individual level how we can explore. Again, this is the nursing notes that student would have put forward at a glance. You can take a case library, have your students run through it, and really start to pull the threads out on some really high level pieces here. On top of, again, to Dr. Doherty, Dr. Ojeda's point, how effective clinical simulation is as a whole, giving them the confidence to be able to play through these in a safe place where you're allowed to make mistakes and get that positive feedback, have that guided learning journey with that preceptor around, does nothing but help build confidence up and make those students stronger and ready to go for their nursing rounds. So, Shannon, I will turn it back over to you. And I won't forget the plug again. I've got a survey that's out there. We would love to get your feedback on these. So I want to make sure that we have that down there in the chat.
Thank you so much, Andrew, for the demonstration and for the reminder for the survey. We wanted to just leave the space open right now for anyone that had any questions about anything that Drs. Doherty or Ojeda went through, or any questions for Andrew about the iHuman patients simulation. The floor is open. And I'll give it just a minute or so. And if we don't have any questions in the chat, then we'll go ahead and close out.